is not a substitute for medical consultation. You should always consult your physician for any health problem or medical condition. And then we're actually going to go right into the agenda. We're going to do a little bit of a Project Echo series overview. We're going to do some introductions with our main speaker for today. And then we'll go into the presentation, the case study, and then we'll have time at the end for question and answer. So just again, the Project Echo. So Project Echo is a movement to demonopolize knowledge and amplify local capacity to provide best practice care for underserved people all over the world. And the ECHO model is committed to addressing the needs of the most vulnerable populations by equipping communities with the right knowledge at the right place and at the right time. And so now I'd like to turn it over to Dr. Ishan Patel, who is our speaker and our case study participant for today. Dr. Patel, if you'd like to give an introduction of yourself before we start, and I will hand it over to you. Thank you.
Hi, good morning, everyone. My name is Ishan Patel. I'm one of the oncologists at Robert Wood Johnson Barnabas Healthcare System. My focus is lung cancer, and I see patients at both Robert Wood Johnson Somerset Hospital and Cancer Institute of New Jersey in New Brunswick. Beside clinical oncology, I have some other roles such as a lung cancer screening program. I oversee our screening program at Somerset and Hamilton area. It's a very robust program, and a lot of people, there is still work needs to be done out there for lung cancer awareness and screening. We're going to talk about it today in the talk, but hopefully we have more and more patients screened earlier, and we can have a better outcome with those patients. So that's certain things that I do with the system. I'm assistant professor of medicine for Rutgers Robert Wood Johnson Medical School, and we will talk today about lung cancer overview from screening to diagnosis. What are some new ways we have changed making diagnosis for lung cancer and new treatments, right? Nowadays, more lung cancer patients are living, so the mortality is still number one cancer that people die from, but they're living longer and with good quality of life because of a lot of new treatments, and we're going to have some overview on that. So what is lung cancer? Lung cancer basically is a cancer that starts anywhere in the lung. It can be from the bronchus, which is a pipe that delivers the oxygen to our lungs, or towards the lung parenchyma, which is a tissue where the oxygenation happens in our body. Cancer starts when the cell in the body begins to grow out of control, and usually we do have a good mechanism to control cancer, but sometimes because of aging, stress, low immunity, these cells cannot undergo self-death, and it continues to grow out of proportion. How common is the lung cancer? It's a very common, is the second most common cancer, not including the skin cancer. Of course, the most common in men is prostate, and in the female is breast cancer. Lung cancer is the second most cancer for both. According to American Cancer Society, for 2024, estimated new cases are 234,580, which is 11.7% of all new cancer cases. And deaths are still, if you see, 125,000, which is 20% of all cancer deaths. So highest mortality among all cancers. Type of lung cancer. So usually it's divided into two big buckets, small cell and non-small cell lung cancer. Non-small cell lung cancer is the most common one and is about 80 to 85% of lung cancers. It's divided further into squamous cell and adenocarcinoma, which is the most common ones that we see. Adenocarcinoma is the one that arises from the glands of the lung. Squamous carcinoma is um, associated mostly with smoking. Small cell lung cancer is 10 to 15% of the lung cancer, but it's most aggressive kind of lung cancer. It grows and spread very fast compared to non-small cell lung cancer. Non-small cell lung cancer can grow over time. Sometime it can be even 3-4 years, but small cell lung cancer is few months that it starts growing. So unfortunately, most of the patients with small cell lung cancer have a poor survival compared to non-small cell lung cancer. It has also highest rate of recurrence. We have more and more new modality, and I'm going to talk about new targeted therapy. We're trying to delay the recurrence as much as we can. And today has been the most exciting time than ever that patients' recurrence rate has been lower than historical times. So what are some risk factors for lung cancer, right? We all know tobacco smoking, and smoking stays still the far most leading cause of lung cancer. 80% of lung cancers are from smoking, but this data I think is changing a lot, and we are finding out more and more that now less people are smoking, but there are more and more other risk factor that has been contributing to the lung cancer. Of course, the longer you smoke, the duration of smoking has more chance, a greater risk of developing lung cancer. Cigar smoking and pipe smoking are also as well known to cause lung cancer as cigarette smoking. Secondhand smoke, that's one thing that a lot of people don't talk about, but exposure to secondhand smoking is also known to cause increased risk of your lung cancer. Secondhand smoking causes more than 7,000 deaths from lung cancer each year. So I still remember a lot of the patients, they never smoked, but they had parents who smoked, or they worked in a place where indoor smoking was very common at the time in 70s and 80s, and those patients are also at high risk. Exposure to radon. So being in New Jersey, I think that's a very top on the list. And if you go on a New Jersey radon site, you can find the different communities where there is high radon exposure. But radon basically is a radioactive gas that is breakdown from uranium in soil and rocks. You cannot see it or smell it, so it's very hard to know if you are exposed to it. Is very common usually in the closed area in the basement. Radon should be checked in all basements usually. It requires very high exposure to radon and a constant exposure, but it has been linked to lung cancer. So that's something environmentally we can change for ourselves. Exposure to asbestosis. This has becoming less and less now, but if you have a parents or someone who has worked with asbestos in the past, right, such as mines, mills, famous in Somerville, there was Johns Melville mill that was exposing patients to asbestosis. Textile plants, insulation plants, those are several type of mills and plants that use asbestosis, and it has been linked for, if you're a worker there, it has been linked to lung cancers. Lung cancer risk is much higher if you're exposed to asbestosis and if you're a smoker, right? So it's a double whammy that you're exposed to two major risk factors. People exposed to large amount of asbestosis also have mesothelioma, which is a different type of lung cancer, not as common anymore, but this is what arises from the lining of the lung. And nowadays there are much better regulation, but this is more for the patients who have worked in the past with asbestosis. So what are some new things that we have discovered in last 10, 15 years, and something that we do not think about, right? But I do see, and being in a lung cancer space and seeing a lot of patients and who are non-smoker and develop lung cancer, and when we take that detailed history, we do find different carcinogen that is found at workplaces. So somebody who is working in a plastic companies or companies who are dealing with a lot of chemicals. So uranium inhaled chemicals such as arsenic, beryllium, silica, vinyl chloride. Those are the lot of chemicals that you see a lot of the plastic companies, a lot of the companies use, and just those are linked, of course, to the very low risk, but this is something to keep in mind at the work exposure. I think you have to have a regulations at work, make sure you are not inhaling a lot of those products, strict PPE use like mask and things like that can decrease your chance of developing lung cancer. Something new that a lot of people, and there is a lot of excitement around it in the news in terms of diesel exhaust, right? So now we have warehouses in our suburbs where we are living, right? So I was talking to a lot of the communities and they're worried about diesel exhaust. And by all means, yes, I think it has started being linked to having lung cancer, but how much diesel exhaust, how much that data is still not um, available. So we are not sure at what amount are you constant exposure. But that's something that's new and people started developing a lot of data around it and they want to see clear correlation in terms of how much exposure can lead to risk of developing lung cancer. Um, Certain dietary supplements such as beta carotene, and this is only for patients who have smoked for a very long time. So that has showed in two larger study that it has shown increased risk of lung cancer, but only in a very long-term smoker. So not for healthy individuals. Risk factor that you cannot change, right? So previous radiation therapy to lung. So we see a lot of patients who had history of lymphomas in their 30s, breast cancer, especially women developing breast cancer early ages now in 50s and 60. Part of the breast cancer therapy is doing lumpectomy and then you get radiation to that site. So the radiation to the breast still the lungs are right behind the chest wall and do get a little bit exposure and has the secondary chance of developing a cancer. So something that definitely to keep in mind. Air pollution in the cities, as we mentioned, that a lot of warehouses in our community and a lot of diesel exhaust that I guess we can change, but again, due to the nature of economy and due to nature of how things works and our consumerization, I think we can be uh, more active about avoiding diesel exhaust, but I think the air pollution is not getting better, especially with the fires, right? And we see that when there was Canadian fire and the fires in western side of the United States, the air pollution index goes very high. So those are the things. Natural disaster we cannot change. Personal or family history of lung cancer. Family, I think it does not run lung cancer. It's not a genetic inherited condition. Very few, if any. Mostly, it's been seen that if the same family has multiple lung cancer, that means they were exposed to certain things, right? So if you're living in the same house, you probably had same exposure to radon or asbestosis or whatever. The exposure was similar, and that's why it run in the family instead of having genetically predisposition. Factor with uncertain or unproven effect. So smoking marijuana and e-cigarettes. So nowadays we have changed our smoking cigarettes to e-cigarettes and marijuana, right? That has not proven anything yet because it's very new, the 10, 15 years now that people started doing it. So we need a long-term studies and we'll see what happens. But what I can tell you is like marijuana smoking is definitely still injurious to lungs. Also, cigarettes, vaping can cause a lot of lung damage. We have seen a lot of young patients in the hospitals with the lung damage and inflammation in the lungs. So if you look at the pathophysiology of cigarette causing damage and over time that inflammation leading to cancer, if you apply that same way, possibly smoking marijuana or e-cigarette can also similarly will increase risk of lung cancer, but only time will tell. Longer longitudinal study will tell us that. Talc and talcum powder, there is a lot of talc involvement for GYN cancers from the talcum powder, but it has not proven anything in terms of lung cancers. What are some things that we can do? What are some prevention that we can do, right? So, of course, the first most common is the tobacco prevention. So, if you know somebody who is smoker, or still smoking, those patients are definitely, there are a lot of ways to quit smoking. New Jersey has a program, is a free program, is a state program to help patients quit, which gives them enough resources in terms of behavioral resources and also resources for nicotine replacement therapy free of charge. So please look into that. So tobacco prevention is definitely top on the list. Diet, nutrition, so healthy lifestyle, healthy diet, less processed food, maintaining good weight, also exercising, um, stress-free life, good sleep hygiene. Those are the things that definitely recommended to decrease the risk of cancer. Early detection. So we're going to talk about the lung cancer screenings now, right? So now lung cancer screening is available and it's usually done with low dose CT scan every year. Lot of people, we got mammograms down, colonoscopy down, but we still are not doing good in terms of lung cancer screening. And I think the reason is it has a strict criteria right now and is only available to either current smoker or former smoker. And I think that's why the awareness is not as much right now, but it's changing. A lot of the primary care doctors are adopting that. As I said, we have a lung cancer screening program at Robert O. Johnson, Barnabas, and a lot of the hospitals start developing lung cancer screening programs. So hopefully we will change we will find early detection for a lot of our patients. And with guidelines is being more and more relaxed in terms of the age group now, and hopefully it's available to everyone who are also non-smoker as long as they have some risk factors. So lung cancer screening, what is the screening? Is a test that we can detect cancer before any symptoms develop, right? Like any other screening. Symptom of lung cancer typically do not appear until disease is in stage 3 or stage 4. So we want to, and when stage 4 is of course not curable, stage 3 is high risk of recurrence. So we want to catch the patient in stage 1. That is the better outcome for those patients if you catch it early. Why hasn't lung cancer screening been routine? Because until now, there was not an effective test. In the past, they used to do chest x-ray, which showed no benefits. There was no change in lung cancer deaths. So there was a big nationally lung cancer screening trial that was done between 2002 2007. Over 50,000 patients were included, which was high risk of lung cancer. At that time, it was defined between 55 to 74 year of age, current and former smoker, and then they were randomized to annual low-dose CT scan. And this was published in New England Journal of Medicine that showed that those high-risk patients had annual low-dose CT and get detected early stage lung cancer and had survival benefit. So based on that trial, of course, the lung cancer screening started becoming more and more prevalent. So people who got low-dose CT scan, 20% of decreased risk of dying from lung cancer. First time the lung cancer screening has shown to decrease lung cancer deaths compared to historically when they used to do chest x-rays. So results were announced in 2010. And based on that, we do have a lung cancer screening. Now, criteria has changed. Before it was 55 to 74, but as from 2010 to 2020, 22, there was benefits and the data was collected that more and more patients are being benefited from doing those lung cancer screening. I think we started relaxing the criteria, and now the new criteria, this was changed, if I recall correctly, last year in 2023, that it changed to age 50 to 80 now, so a larger group. Currently smoker or have quit in past 15 years. So before it was, if you have quit within 20 years, and you had 30 pack year history, but now they relaxed that criteria also. So if you have quit within past 15 years, and if you have only 20 pack year history, how do you count pack years? So number of pack of cigarettes smoked per day times number of years, and that's your pack year history. So if you have a 20 pack year history, you qualify to get a lung cancer screening. So I do not know if we have primary care doctors on or primary care nurses. This is something you should be screening when you are seeing the patients in your clinic. This is a very important. Because of lung cancer screening, I think the new lung cancer cases continues to decrease, partially because people are quitting smoking, and also because I will say the number of lung cancer mortality has been decreased because we are catching them early on and they're being cured. So diagnosis, how do we diagnose patients, right? Cancer is a diagnosis of tissue. So we always need some form of biopsy to diagnose those patients. And also that has got better and better over time in terms of how do we biopsy the patient. So before we used to do open biopsies where they used to get big surgeries for the biopsy, but nowadays we have very minimal modality, minimal invasive modality to do tissue diagnosis. So two most common ways are CT guided biopsy. So interventional radiology doctors, basically, if the lesion is out in the peripheral area in the lung, they can go from outside the chest wall with the needle directly to the nodule or the tumor and take a biopsy. It's done under CT guided, so the needle is advanced, exactly know where it's going. So it's very good in terms of the accessibility and efficacy. If the lesions are more central, of course, you cannot go all the way from outside. That cause increased risk of your puncturing of the lung. So it's done through bronchoscopy. Basically, patients has bronchoscopy is a camera that go down the throat and to the breathing pipes and try to take the biopsy through the breathing pipes with the very small needles. And this is usually done as outpatient, in and out procedure. Patient doesn't even need to be hospitalized, and very effective and gets multiple tissue for multiple testing and tumor markers that we need. So both are very effective way of doing it, diagnosis. What are some treatment? So lung cancer depends on its staging. There's multiple modality that we use to treat lung cancer. Surgery, targeted drugs, immunotherapy, radiation. So stage one, lung cancers are usually just surgery and that's it. Stage two lung cancers are usually surgery followed by chemotherapy. Stage three, if they're unresectable, usually get chemo with radiation, followed by immunotherapy. And stage four depends on their molecular and genetic markup. They can get targeted therapy or immunotherapy or combination of therapy. And it's a very exciting time in last 10 years, amount of new medications we have for lung cancer patients, more targeted, more precision medicine. And immunotherapy is something that has been also introduced in lung cancer in last 10 years. It started with the melanoma. President Jimmy Carter got that as a part of clinical trial for his melanoma with the brain mets. Immunotherapy is a very exciting time and it works great in lung cancer. Very minimal side effects, and patients have very good quality of life, and now they're living longer because of all those treatments. Surgery nowadays, I'm just going to talk very briefly about each modality. Surgery nowadays are minimally invasive procedure with smaller incision. It's not a open surgeries anymore. It's done under video assisted now with a very small incisions, like 2 or 3 incisions. Patients have very fast recovery. Usually in 1 or 2 days they get discharged. So it's not open surgeries anymore. Less pain, faster recovery times. Now there's a new development which is not standard of care right now, but hopefully in the future, we're going to do something called brachytherapy, where radioactive seeds are put in chest after the tumor has been removed. This way we can decrease the local recurrence. This has done very successfully in prostate cancer, and I think hopefully in lung cancer, it can also show benefit in the future. Radiation therapy. So radiation is basically special rays of radiation that's delivered to certain areas where it kills cancer cells. Before the radiation therapy had a lot of side effects, but nowadays, because of the newer technology, newer machines, having more machines that are computer algorithmic way to give proper radiation to specific site. It's more precise, more accurate without damaging the good healthy tissue around. Proton therapy, radio SRS, which is, as I said, more like a point radiation that deliver the radiation to the particular tumor. Intensity modulated radiation therapy allow tumor to be targeted more directly while sparing nearby healthy tissue. Radiation are used a lot in health in curing, also decrease in size for better surgical outcome at times, and also it used as a palliative to alleviate symptom of pain or if people are having breathing issue, things like that. So we have used the modality of radiation for a lot of the different reasons. My area is treatment, systemic treatment, right? So current treatment overview for advanced or metastatic, so stage 3 or 4 cancers. There are multiple different modality. In the past 10 years ago, it was just chemotherapy. Chemotherapy is still part of some of the regimen because it works, and I think it requires as a backbone for newer therapies to work better at times. But chemotherapy is standard of care for a lot of the patient currently, or as I said, in a backbone of either immunotherapy or we can use it with targeted therapy. Chemotherapy kills all rapidly dividing cell, right? So the good part is it works very effectively to kill cancer cell. The bad part is the side effects because it kills all rapidly dividing cell in the body, which is the hair cells. That's why we have hair loss or patients with the lining of our mouth or our GI tract. That's why where you get a lot of nausea and trouble with the ulcers in the mouth. So if it's not well tolerated, a lot of people can have decrease in quality of life. And that's where the newer therapy works very good. And nowadays, that's what we do. We give chemotherapy only for 2-3 months and then stop it. And patients go on a maintenance therapy and they have good quality of life with better outcome. Targeted therapy, so we have learned over time that lung cancer can have different genomic mutation, different alteration that has caused the cancer. And by giving more precision medicine, targeting that mutation, patient has less side effects and better outcomes. So that's a targeted therapy. Now, not everybody has certain target, so we have to check everybody. If they do have a target, then they get targeted therapy. If not, then everybody gets combination of chemo and immunotherapy. And that's the last slide, the immune checkpoint inhibitor. Think of immunotherapy as more like a therapy that helps prime your own immune system to fight against cancer. So cancer cells are very smart, and what it does, it blindfolds your immune system, and those immunotherapy basically takes that blindfold away, so your own immune system recognizes the cancer and kills it. So it works better with very minimal to less side effects. The number of actionable biomarkers has more than doubled in last 5 years. So in 2003, that was the first biomarker, EGFR, that was established that shown that it causes lung cancer. And in 2011, the second one, which was ALK. And then from 2015 to last year, we have so many new mutation that we have found. And not only that we found those mutations, we also have therapy for all those mutations now, more targeted therapy. So again, it's amazing time, and patients are doing well because of all those new targets and more precision medicine. How are we doing in terms of testing? So we are, anytime when we have a tissue, lung cancer patient, have those tissue be tested. If you're at a good cancer center, every cancer center should start testing for molecular markers. Robert Wood Johnson at New Brunswick CINJ and Robert Wood Johnson Somerset, we are very highly dedicated to molecular biology of the tumor, and we make sure everybody gets their tissue tested, particularly for those biomarkers. And testing was not done good until like 2011, 12, and now everybody has started picking up the testing because now we have more targeted therapy, right? So if you have therapy, I think the testing started going up. Now, there is also a new development of something called liquid biopsy. So there was some limitation of tissue testing for those genomic markers. What was happening if a lot of time they do a biopsy, we know it's a lung cancer, but the tissue was not enough to do all those different testing, right? Because we need a lot of testing just to make sure it is a lung cancer or it is some other cancer. So they do a lot of staining, and if they exhaust the tissue, we need a better approach. We cannot put patient, and this used to happen during my fellowship days, that tissue was run out and we do not have enough tissue to check for all those molecular markers. So then we had to get another biopsy done. So putting patients through another invasive procedure. It takes longer, right? Tissue has to be fixated certain way, handled certain way. So there was a lot of limitation with tissue-based testing. And now there was an unmet need. People were not getting enough they were not getting testing for their molecular markers. So in last since 2017-18, we have a new advantage of liquid biopsies. And basically it's just a blood test. And what it does is minimally invasive because you're just taking blood from the patient, but it basically look at circulating tumor DNA in the blood. So cancer, when it dies, it releases all this DNA into the bloodstream. And just from doing this blood testing, we were catching those circulating tumor DNA and doing molecular markers on them. And then we found out that patient had certain molecular mutation. That way, it's faster. It does not require another biopsy. And patients started getting therapies early on instead of waiting for the repeat biopsies and repeat molecular testing. So from 2-3 months lag time, we came down to 7 to 10 days. So that's something new and I think very exciting that now has become standard of care to have a liquid biopsies done for the lung cancer. This is not for diagnostic purpose. You still need biopsy for diagnosis of lung cancer. Liquid biopsy is only to look for mutations in the cancer. So just to keep that two different things. So nowadays, adenocarcinoma used to be one entity before. If you have asked me 20 years ago, I was like, yeah, lung cancer. Now we divided the lung cancer, adenocarcinoma, in all these different buckets. So there are EGFR lung cancer, KRAS lung cancer, MET mutation. So all those mutation has different targeted therapy and treats differently. So if I have lung cancers versus somebody else versus third person, all three can have different therapy and different outcomes. So nowadays prognosis is also very hard to tell patient. I tell patient, look, we do not know enough. There is so much new thing that happened in last 10 years and every cancer is so different. My cancer might be very different than second person cancer or third person cancer. So, and that's because of the different genomic biomarkers that's driving the cancer. The biomarker detection, because of those tissue, because of this blood-based testing, liquid biopsies, the biomarker testing has been improved and also time to treat patient. So patients now getting their targeted therapy much faster within sometimes 14 days to 21 days compared to 3 months where they were supposed to get the targeted therapy. So of course, time to treatment is faster with more precision. So patients are doing better. So what are some goals of biomarker testing? Biomarkers used to identify cancer at early stage when it's more treatable. Biomarkers can help provide information, likely the course of disease. It also helps us choose the treatment accordingly. It predicts treatment response. So we can check the biomarkers after 3 months of treatment. If the circulating tumor DNA decrease, that means patient is having great response. So we can do a lot with those biomarkers in terms of even treatment response and the monitoring of the treatment and disease surveillance. So biomarkers are also important once after cured surgery or cured chemoradiation is done, we can utilize that to check for recurrence. So something that helps us check the recurrence and treat and intervene earlier rather than wait for them to start showing up with a large disease burden on the scans. Immunotherapy, as I was saying, our T cell, this is our immune cell, and the tumor cell, what it does, it basically binds the PD-L1. If you see the blue linkage arrow, basically it's blindfolding our T cell, our own immunity, so it doesn't recognize tumor cell. It continues to grow. But the PD-L1, that's the red triangle, and the um, uh, yellow triangle you see basically blocking these treatments are blocking those areas, so the tumor cell does not engage with our T cell. It cannot blindfold our T cell, and that way our T cell gets activated and kills the tumor cells, as is shown on the right side of the screen. And mutation burden. So immunotherapy works very well as in cancer that has very high mutations. And if you see on this diagram, lung cancer, I highlighted in the red/orange color, has very high mutation burdens usually. And that's why immunotherapy works very well. And that's another marker we utilize to make sure a patient will be benefited from immunotherapy or not. Just another a case. This is my case that I just saw her yesterday. After I saw her, I put it on the slide. So it's a great case. She's a 55-year-old female, history of pulmonary embolism and DVT. She came to the ER with shortness of breath a few months ago. She reported having shortness of breath, to very severe that started causing her functional capacity to go down. Even she couldn't ambulate in her house to the bathroom without getting short of breath. She said it was started like few weeks, but in last 2 days it was getting very worse. She also reports dry cough. She reports some numbness in her hand, but no other neurological symptom. Imaging in the ER showed some lymph node in her lung and some nodules in the lung. There was a 2 centimeter mass. And of course, with the lymph node and the mass, we thought she most likely has a lung cancer. She's never smoker, no secondhand smoking, decreased breath sounds on the exam. We did do MRI of her brain because of the numbness in the hand, and she did had small metastatic focus in the brain, so it had already spread to the brain. And unfortunately, a lot of time when we diagnose lung cancer patient, they're in advanced stages. This is very common scenario. Patient underwent the EBUS guided biopsy, which did show positive for lung adenocarcinoma. When we see the patient in the first time, we send the patient for the tissue and the liquid biopsy that I was talking about, the blood, for mutations check. And this patient had something called ALK mutation. And because it has a good therapy nowadays, ALK mutation is just the pills. So EGFR, ALK, ROS, a lot of those are just pill. And she does not need chemo, she does not need immuno. She was started on targeted therapy. Targeted therapy, the good part about it, it also crosses blood-brain barrier. So you don't need radiation. She was very minimally symptomatic with this numbness. So we started the therapy. We did not even give her radiation because the ALK inhibitor targeted therapy does go to the brain, and it will also work on the brain lesion. This patient has been on therapy for 6 months now. Her recent scan shows great improvement, 80-90% reduction in her cancer. Also, the brain lesion is completely resolved. And this patient is continued to be working. She had a vacation. She went to her house in Portugal, and she had grandchild this month. So, she's living good life with good quality of life, and she's doing her daily activities. And those patients had good response for many years. So compared to historic data when this patients only lived for 6 to 9 months. Now those patients are living longer. I have patients with EGFR mutation living in years, like 5 years and even beyond, and continue to do their daily activities. And that all been possible because of this new targeted therapy and new development, how we catch those mutation in terms of liquid biopsy. So this is a great case I thought I will share. And yeah, I think that's pretty much it. I just wanted to give you a little bit overview on the lung cancer today. So screening, of course, more and more we need to be aware in the community. Screening is not for everyone right now, for at future, hopefully that it changed the criteria and enroll more patient with different risk factor. Right now is only limited to either former or current smokers who had certain time history of smoking, and also between age 50 and 50 to 80. Lung cancer screening has been utilized by a lot of our community patients who have history of smoking, and we have last year we got 4 to 5 patients in early stage lung cancer. So that's great. Those patients are cured now after resection, so it's good for those patients. In far of detecting early lung cancer, there is new AI-based software that detects all the lung nodules. So if anybody goes to the ER or getting a scan for different reason, but they have a lung nodule, and if they have suspicious feature, the AI is detecting them more precisely nowadays, and they will be followed by the hospital in terms of recurrence to make sure that they are not cancerous. There are new modality in surgeries. There are new modalities in radiation, which is more precise and more accurate with the less side effects, good, faster recovery times. And the last is also advanced stage cancer. They're also doing well because of the new targeted therapy and immunotherapy. So I think this is just a little bit overview from screening to diagnosis to treatment options we have nowadays.
Awesome. Thank you so much, Dr. Patel. That was a fantastic presentation, and it was a great case study. We actually have a few questions if you have some time. I see Colette has her hand raised. Feel free to mute yourself.
Yes, good morning, everyone. Thank you for this wonderful presentation, Dr. Patel. I'm actually a non-small cell lung cancer survivor, my 9th year living with an upper left lobectomy, EGFR exon 20, all of these acronyms. And I'm in an affinity group with other survivors, never smokers, stage 4 with brain mets. And I'm wondering if there's anything that we can look forward to as far as screening for never smokers, because we're marginalized as far as screening is concerned. And I'm hoping the science will pay more attention to us with as far as screening. If there's anything you can share with regards to that, I'd appreciate it.
Yeah, unfortunately, as of today, there is nothing in terms of screening for non-smoker. But that being said, I think everybody should have screening option, right? Especially as I said, if they have this other high risk features. Circulating tumor DNA, the technology has been very advanced, and the company which has been pioneered in circulating tumor DNA have a test that they established, basically is a blood test that can pick up any circulating tumor, and it can tell you if it's lung cancer or colon cancer or this cancer. So it's been established and they got approval. It's called Shield, and they're only approved for colon cancer right now. But the company is gonna future looking for pan cancer screening. So in 5-10 years, it might change, and it will be just a blood test at your doctor's visit, primary care doctor, who's gonna just draw a blood and will tell you if you have a circulating tumor from anywhere.
Go ahead, Al. I think there was a question I saw that you were gonna answer.
Yeah, thank you. I appreciate everything. I do have some questions that have come through the chat. Monique says, what size typically must a lung nodule be for it to be biopsied? I've seen some say that they monitor until it grows, which I'm sure can be distressing to a patient.
Yeah. So ideal size is 1 centimeter. Anything below 1 centimeter is very hard to biopsy, and you can have false negatives. Of course, there are some rules to it. If any nodule has doubling time within 6 months, so it changed from 4 millimeter to 8 millimeter within 6 months, then it's most likely malignant. It's not 100% rule, but those are usually rules we go by. 1 centimeter is ideal size that we like to biopsy. But let's say, as I said, if somebody has a doubling time very fast and has a very high risk feature. They were smoker and this nodule has irregular borders, and there are certain criteria that shows that is a high risk nodule. Certain time we don't even biopsy, we just take it to surgery and just try to take that nodule out. So there are certain criteria, but there is never 4 mm, I think 6 mm is the cutoff where we like to wait and watch because it's too small for us to know what it is. But as I said, nothing set in the ground. It's all depends on patient to patient, risk factor, previous imaging, doubling time, how the nodules, the characteristic of nodules, things like that.
Great, thank you. I appreciate this. And I'm seeing some more questions come through. So Donna says, are there genetic testing recommendations for family members of patients with lung cancer, particularly those that are non-smokers or decreased risk factors?
No, so genetic lung cancer has not found genetically linked. So on breast cancers, pancreatic cancers, those ovarian cancers, those are very genetically linked. So there is always, and colon cancer, we always do genetic testing for those. Lung cancer is not genetically linked. I think if you have multiple family with the lung cancer, as I said, I think it's probably because of the exposure of the same things because they all lived in the same household. So right now there is no genetic testing. We don't do it for lung cancer. That being said, I mean, if a mother and one other like first degree relative had two of them had lung cancer, the third person who lived in the same household, same environment should be more cautious and probably get at time to time if you have any symptom, get a scan done.
Thank you. I think there is somebody in the chat asking, Colette, could you just confirm the name of the blood test to detect colon cancer?
It's called Shield.
Shield?
Shield. SHIELD.
Thank you. And then I just had one last question that came through. So with the liquid biomarker testing, are you able to identify how aggressive the lung cancer is?
So yes, because certain biomarkers, we know that those patients might have more, so certain biomarkers does have prognostic indication. So certain mutations are more prone to have faster, more aggressive features and faster recurrence rate, or have less, I would say more resistant to therapy. So yes, certain mutations we can identify, we can say the prognosis based on those.
Thank you. And then I'm also getting another question here. Can mold in the home cause cancer?
I do get this question a lot whenever I give a lecture. Not known yet. Mold has known to link to a lot of interstitial lung disease, so basically inflammation in the lung, and that cause chronic like COPD kind of changes and require oxygen, but not the lung cancer. Now, of course, can it lead to lung cancer? Maybe anything that has chronic inflammation, but not enough evidence of data to support that.
Thank you. I think that's all the questions I have right now. Unless anybody else has anything, feel free to raise your hand. And you can go on off mute or drop it in the chat.
Thank you. I actually had a question myself, Dr. Patel. It was very informative. This is more of like a personal spin, I guess, on things, but I actually have a loved one who had never smoked a day in their life and had been, suffering from like certain symptoms, and they were actually diagnosed with like pulmonary fibrosis a few years ago after seeing a few different physicians, I guess. I guess my question is, how can healthcare providers, better educate their patients about like lung cancer screenings and screening options, just because, I guess the physician at the time, didn't really dive too much into his background. And he was actually someone that worked in the city during 9/11 and during, the time surrounding that, and never really dug into that. And they're assuming that that's probably the case because he was never a smoker. So is there any way, we can increase education around like lung cancer screenings or options? Because I know unless you have certain risk factors, normally they're not going to tell you about that unless you've been a smoker or a former smoker or anything like that.
Yeah, I will say just more and more community engagement like this and primary care. We try to do grand rounds around it. We engage a lot of CME activities with the primary care. Um, I try to talk at the community events with the population to be aware, raise awareness regarding those risk factors. So um, I always say whenever non-smokers start having any issues, lung related, anybody with the shortness of breath or any new changes in the lung but has never been a smoker, I always question. And unfortunately, by the time it comes to me, it's very late. I think it's true to have start with the primary care providers. But always question as a primary care, like, hey, why this patient will have any lung-related symptoms that's ongoing for a long time. He's a non-smoker. There has to be other risk factor. We need to dig further into it. So I think, yeah, awareness, I will say, in community and primary care physicians and a lot of the primary care providers.
Awesome. All right. Well, thank you so much, Dr. Patel, for your time and for, staying a little bit longer. I know your patience, but thank you for answering the questions. If we have any questions also come through later on, feel free to reach out to you, or if, they would like to speak to you more, we can always give them your contact information if you're okay with that as well.
That's fine.
So we're just going to move into the rest of the presentation. Let me just share my screen.
Thank you, everyone.
Thank you, Dr. Patel. Let's see, and can everybody see my screen now? Perfect.
Yep.
All right. And so we're just gonna come to the end of the presentation. So again, in our state, we have New Jersey SEED, New Jersey Cancer Education and Early Detection. Ellen will be dropping the link to the facility search. So if you need any help getting screenings for some of the preventative cancers, they are located in all, I believe, 21 counties within our state. So please feel free to look them up if you or anyone that may need assistance. And we just want to thank you again for attending today's session. Ellen, again, drop the link in the chat, as well as with our Screen New Jersey patient navigation team. If you need help getting any of those resources or have any questions, feel free to send them an email, even give them a call. And if you could just fill out this session survey, we would really appreciate it. Just let us know, things that we can do better, or even topics that you'd like to see. Or if you have questions, again, for the speakers, you can always reach out to them. And we always appreciate your feedback so that we can continue to do this to bring information to our communities and to our other healthcare workers. And again, please just give us about 2 weeks, for our resources. Please sign up for our Mighty Networks community. We'll put the recordings, any of the resources that we have and put together will be available there. Just give us about 2 weeks as we go through all of the logistics. And please join us next month. We'll be doing a session on cancer equity. So if you have any questions in the meantime, please feel free to reach out to us. Our newsletter should be coming out in about 2 weeks again with all of this information. So again, thank you, Dr. Patel, for today's, very informative and fantastic presentation. And if you guys have any other questions, please feel free to reach out. And yes, the recording usually takes us about 2 weeks to put together. We just want to make sure we go through slides and everything is up to date. And then it will be on our Mighty Networks. I saw that Alice had posted that in the chat. Thank you, everyone. Have a great rest of your day, and we appreciate your attendance.